The approved indication for bevacizumab is firstly in adenocarcinoma and in combination with chemotherapy, and in particular with chemotherapy with carboplatin and Taxol. And this is based on an important trial published on New England Journal of Medicine several years ago. The first name was Sandler. And we know that this was the first drug who gave a survival benefit in treating adenocarcinoma patients. Unfortunately, the story in Europe was slightly different because we had a European trial using bevacizumab added to cisplatin and gemcitabine, and this trial was negative. In the next years, also the combination of cisplatin and pemetrexed appeared on the market, and in Europe, generally we prefer to use the combination of cisplatin and pemetrexed, but carbotaxol and bevacizumab still is a really important strategy to treat this kind of patients. It's important to underline that it's only for patients with adenocarcinoma, and they need to have peripheral lesions and no very uncontrolled hypertension.
Right, so while bevacizumab is a drug we've been studying for 20 years in lung cancer, it's an anti-angiogenic drug. It's an antibody against VEGF, vascular endothelial growth factor. It's been shown to improve survival in combination with carboplatin paclitaxel versus carboplatin paclitaxel alone, ECOG 4599, with a hazard ratio of 0.8. So oftentimes if I use carboplatin Taxol in lung cancer, it's someone who has non-squamous lung cancer and they have no contraindications to the anti-angiogenic agent, meaning they have no bleeding. I would use it in that setting. Nowadays, people have moved towards using carboplatin pemetrexed as the frontline chemotherapy for lung cancer. And the additional benefit of bevacizumab with that combination is somewhat debatable. If someone has excellent performance status, absolutely no contraindications to an anti-angiogenic, I tend to use it. I tend to use the triplet therapy, carboplatin pemetrexed with bevacizumab. But I know that in the community and certainly in other countries, people tend to use just the doublet, carboplatin pemetrexed, usually followed by pemetrexed maintenance.
Anti-angiogenic agents which we use are, for now our bevacizumab is available for many years now, and we use it as a first-line treatment in patients with non-squamous small cell lung cancer. And in general, in combination with taxanes, as we have some scientific evidence that the anti-angiogenic agents work better in combination with taxanes, because taxanes could have a special effect on the endothelial cells, which is increased by the anti-angiogenic agents. In our clinical practice in Western Europe, so in Holland, in my country, then the bevacizumab is not that regularly used because we have other regimens which are not taxane based, and that's why we need a combination with the anti-angiogenic agents. But there are some preclinical data or early clinical data showing that maybe some patients with different kind of mutations, for instance KRAS mutations, may do better on that kind of treatment. So that's something which is now under investigation, and also one of the reasons why we use it in that setting.
Bevacizumab is a drug that we use in patients with non-squamous histology, patients with stage 4 disease. In my clinical practice, I am using bevacizumab in a number of patients with ECOG performance status 0 or 1, non-squamous histology, without previous hemoptysis, and without tumors with central location with invasion of great basals. We prescribe the drug in combination with a platinum doublet, and the usual treatment is 4 cycles of chemotherapy plus bevacizumab, followed by bevacizumab as maintenance. I am treating a number of patients with EGFR mutations who progress to an EGFR TKI, and in the rebiopsy, we are unable to find the T79M mutation. For these patients, EGFR mutations at progression to an EGFR TKI and without the T79M mutation, sometimes I also prescribe a chemotherapy plus bevacizumab.
We decide there is no real difference among the two regimens, so I'm saying between cisplatin pemetrexed and carboplatin taxol bevacizumab, because there are no direct trial comparing the two regimens. There is only one trial comparing the two regimens, saying that the quality of life could be better with the combination of pemetrexed. So generally, we decided to give carboplatin taxol bevacizumab in patients in which we need a very short shrinkage of the disease, because the response rate of this regimen is very high. But again, I can say that there are no major differences between the two regimens.
Bevacizumab is used as a first-line treatment in combination with chemotherapy in metastatic non-small cell lung cancer for many years now. But we are trying to introduce that also in other settings. So we have now seen a positive study where it was used in combination, bevacizumab used in combination with erlotinib in EGFR mutant non-small cell lung cancer. And we saw that there was an increase in the activity of erlotinib when you combine it with the bevacizumab. So that's, again, a whole new field of treatment in patients in whom we didn't intend to use it before. So that's a new concept which is coming into place. And the other thing is that we know that bevacizumab is used as a maintenance treatment after chemotherapy. So you give them 4 cycles of chemo, 4 or 6 cycles of chemotherapy, and then afterwards you continue with the bevacizumab. But you have also some results showing that when you use the cisplatin pemetrexed, you can use also in combination with bevacizumab, and then when you continue on pemetrexed bevacizumab as a maintenance, that's probably more effective than the pemetrexed alone. So all new results in a new concept, but we have to look at how to combine this to get the optimal treatment for the patients.